get started to make sure you have plenty of time. So good morning, everyone, and welcome back to our weekly CMR conference series hosted at VCU. Very pleased to welcome Dr. Jennifer Jordan as our speaker today. Dr. Jordan's an assistant professor who is duly appointed in the VCU College of Engineering and also the VCU Pauley Heart Center, and has her own several lines of research within clinical populations and cardiovascular magnetic resonance. And so she's going to be speaking with us this morning about imaging artifacts and CMR, something that's extremely important to optimize our scans. And just a reminder to everyone that these sessions are CME and MOC accredited, so don't forget to text the code on the screen to the number provided. And with that, we'll go ahead and turn it over to Dr. Jordan. Thanks again.
Thank you, Corey, and good morning, everyone. So this is always a great talk to just hit on, as Dr. Trinkle was saying, every other year here. And there's a lot of factors that go into imaging artifacts. So we'll cover those today, and certainly we won't be able to cover all the potential artifacts, but hopefully this is a good refresher for some of the ones we see frequently, as well as some more interesting, less common imaging artifacts, and understanding the origin of these is really key so that you can make the adjustments in real time. So here are our learning objectives for today. We're going to start with, first off, just defining an image artifact, and then I'll describe some CMR artifacts as well as non-CMR artifacts that we come across too, because we often do scouts or investigations of other areas. So just understanding some general artifacts is also important. So what is an imaging artifact? If you look it up in good old Webster dictionary, it says it is something that is observed in scientific investigation that is not naturally present, but occurs as a result of the investigative procedure. And I misattributed that. That's for the Oxford Dictionary there. So if we look at more specific to the MR world here, one of the definitions in the literature is that it can be defined as something that is visible in an image, but is artificial and is often detrimental to diagnosis. So more often than not, we're going to want to avoid these artifacts or remove them where we can. Sometimes they can actually be beneficial, but generally speaking, they're detrimental to the diagnosis. And then if we go one step further, we can look at another, I'm getting advancing. There we go. Here's another definition that most artifacts can only be corrected during the acquisition, and thus the accurate and timely identification of the artifact and its cause is crucial for pursuing the accurate final clinical diagnosis. And so that's really why we want to look through these image artifacts today, is being able to recognize first what it is, and then how we can adjust and reacquire the images free of those artifacts while the patient's still on the table. And certainly some sequences are more urgent to recognize the artifact and adjust, such as first pass perfusion images or LGE, where we have a timing question. But generally speaking, we'll have time within an exam to look at the artifact and reacquire. Another point of clarification is the difference between noise and artifacts. So noise is something that occurs randomly in the image, whereas artifacts are structured. When we think about adjusting our image acquisition, noise cannot be eliminated, but the artifact may possibly be eliminated. So that's another thing to consider. When we look at our images, noise will appear grainy and can obscure true features in our image, whereas artifacts may get interpreted as features themselves. And that's the big component that we're trying to avoid here, is we do not want to misinterpret something on the image as a feature, or likewise miss a feature that's truly there due to the artifact. So when we classify the types of cardiac MRI imaging artifacts, I like to think of them as three specific areas. First, we have our non-specific MR imaging related artifacts. Then we have our artifacts related to the cardiac specific sequences. And then finally, just general artifacts that are caused by our ferromagnetic materials, and they present in different ways. So we'll look at some examples of that. First, we'll go through the non-specific MR imaging artifacts that you see listed here. So on image on our left here, you can see we have a coronal scout image of a patient. And if you're paying attention, you might recognize two important features. First, that the coil is too low over the cardiac region. So you see that we have hyperintensity down in the abdominal cavity and not as much up here near the top of the image. And second, the heart is not near isocenter. It's a little bit too high up in our image. So if we reposition the anterior coil array over the heart, and then we reposition the patient so that the heart is at isocenter, we can see that we have improvement in our image here. So things look much better. And you'll also notice that the signal to noise ratio is higher. If you're not in a dark room, this could be difficult to appreciate, but to look at noise, I like to look in areas where I'm not anticipating a lot of signal, like the lung cavity here. So it's much more grainy and pixelated on the left. But on the right-hand side, when we've repositioned our coils, we have higher signal to noise. So SNR is literally the signal divided by the noise. And so when we remove the noise and boost the signal, our SNR increases overall. And then one other way you can verify that your coils are accurately positioned is that you could do an orthogonal scout. So in this case, we have a sagittal scout. And you can see between the arrows, the area of hyperintensity at the subcutaneous fat level that bleeds across to our area of interest here. And so we're getting a really nice signal through our area of interest here. So we need to position the coil correctly and do isocenter. Isocenter of the magnet is where we have the most homogeneous signal within our main magnetic field. And so we want to set ourselves up for success by eliminating any other factors where we can. And part of that is putting the heart at isocenter. This is an example of activation of different coil arrays. So this is a standard short axis SSFP SENI image. And on the left-hand side, the images are acquired without the anterior coil array. And on the right-hand side, you can see the improved signal to noise ratio where we've accurately activated the anterior coil. So we get a much better SNR when we're activating the proper coil arrays. Something that happens in all MR systems, whether it's cardiac MR imaging facility or general MR, is that we have monitoring devices, and those all have their own radio frequencies. And when you break down what MRI is, it's really just the measurement of small RF frequencies. So these machines that we're using to monitor, they're necessary, of course, but they can cause some interference with our image. So let's look at these images here. On the left-hand side, we have our perfusion image in a trial acquisition before we have the contrast on board. And what you may appreciate is there's some horizontal lines that come across the image, and that's our phase encoding direction. So then when the perfusion images are acquired in B and C, the perfusion images show, if you have the horizontal lines here, we also, if we switch our phase encoding direction, we get those vertical lines as well. So that can cause some artifacts that in the case of perfusion would go right across our area of interest. And in the far right image, you can appreciate kind of a decrease in the signal that is in parallel to some increased signal here too. So if that's going right through a potential area where we're concerned for hypoperfusion, may be detrimental to the quality of our image scan. Another general MR artifact that we have is the spike artifact. So this is an example of another perfusion image. And what you'll notice is that there's a very regular pattern of interference that appears like ripples at a diagonal across our image. And so what's happening here is that we have regularly spaced lines that are caused by a corrupt data point or multiple corrupt data points in K-space. Going back to our basics of MR, we listen for the RF frequencies and we record them in something called K-space with our frequency encoding direction on one axis and our phase encoding on the other. Then we do a 2D Fourier transform into the image space. So what's happening here is if you have a diagonal line in your image space, if you think about the Cartesian coordinates of your K-space, you have a point somewhere off of the main axis in one direction. So there's some component of X signal and some component of Y signal, thus causing this diagonal reverberation in our image. And the frequency and orientation will thus depend on where in K-space those points are affected. This one's always fun. Sometimes it looks like this to a lower degree, sometimes there's more. But if you look really closely at this image, you'll see kind of alternating hyper and hypo intensity, the way a zipper looks on the front of a jacket when there's teeth missing. And so that's where the name of this comes from. And the zipper artifact presents as lines like you see here, and that's due to electronic noise that's extending perpendicular to the frequency encoding direction. And so in this particular example, what was happening is we have some interference of RF frequency, and they were able to determine that for this scanner, there was actually a defective light that was emitting some RF frequency and getting into all the images. So the zipper artifacts are typically referred to also as RF leak artifacts, and it is most commonly related to our hardware malfunctioning, but it could be due to environmental factors. So if the door to the scanner room, between the console and the scanner room, is not fully sealed, you could have RF leak. If there's been some renovations and there's a patch in the wall where there's not the copper shielding in the wall of the room, you might have an RF leak. That can also be due to things like monitoring equipment, or in this case, a light bulb. And so they can be really frustrating because you're trying to source out something that you can't physically see. And so you have to kind of go through a checklist of all the potential options and scenarios. First off, just try to close the door again, make sure that seals. But you really need to just work through it systematically to remove all unnecessary static electric sources here. So this is one where it's going to be difficult while the patient's on the scanner, unless it is the door not being sealed, and you can just retry that and take another scan. So those are our non-specific MR imaging related artifacts. But this is the CMR conference, so let's pay the majority of our time here to our artifacts from cardiac imaging sequences. So here we have a classic example of a artifact we have to deal with a lot, which is the ECG gating issue. So on the images presented here, we have SSFP semis. And the image on the left is acquired with retrospective ECG gating. And the image on the right is acquired with prospective ECG gating. And what's happening for this patient is that they are in atrial fibrillation, and that a regular heartbeat can be improved if we are prospectively gating instead of retrospectively gating here. And so you can see, just being able to recognize the source of your artifact, you can switch from retro to prospective and then get rolling again for a diagnostic quality scan. Here's another example of a 4-chamber Cine series, and I've got the end diastolic phase in the left column and the end systolic phase in the right column. And the two rows are comparing our retrospective ECG gating with a newer technique called compressed sensing. And so in this, what we're able to do is see that with our compressed sensing, the cine images are able to be acquired in a single breath hold heartbeat. So we're going to have a difference in the general appearance because it is a faster acquisition. But because of this patient having frequent ectopic ventricular beats, we get an improvement in the image quality when we do compressed sensing because we're just imaging over a shorter period. And so we're removing the likelihood that one of these frequent ectopic beats would interfere with our ECG gating. So compressed sensing applies a compression algorithm to the acquisition process, and then it reconstructs the undersampled data. So we natively have less data in case space, and it does the reconstruction with a nonlinear reconstruction algorithm. So it's really a great option when we have difficulty with gating, just to go with this faster compressed sensing. We do often have to sacrifice in situations like this, either our spatial or temporal resolution. And so we can fill the case space in the undersampled scenario in a sufficient way that it can be done in a breath hold here. And here's another example of AFib. So you can see the retrospective gating, the end-diastolic and end-systolic phases here versus prospective gating here. And with this method, the images are continuously acquired through the cardiac cycle over those regular heartbeats. When we have the retrospective gating, when we do the prospective gating, we're actually looking for that trigger, so it can help us avoid artifacts from the irregular R to R interval that we have. If we're not worried about ECG gating, we might have to run into the case of breathing artifacts. And this is really something that comes up with patients who have lung issues or are very non-compliant with instructions or just physically exhausted by the end of a long exam with all the breath holds. So on the screen here, I've got an example of long axis cardiac SSFPs. And in the left image, we have our standard breath held segmented balanced SSFP. And you see there is marked artifact, and it's very difficult to appreciate the border between the endocardial surface and the blood pool. So that would make quantification and diagnostic quality really suffer here. On the right-hand side, we switched to a real-time or prospectively gated image. So you can see we have a difference in our signal, but by using the real-time balanced SSFP parallel acquisition technique, which for our scanner is called SENSE, we're able to prospectively gate and eliminate that motion artifact. And so we can very much, at least in a better sense, delineate the blood pool from the myocardium here. So that's better, but we do have larger pixel size, and that can cause an overestimation of our end-systolic volume. And with an overestimation of the end-systolic volume, that could cause underestimations of both the stroke volume and the EF. So just something to be aware of if you are making those changes due to breathing artifacts, of which you'll often see the ripple paralleling the chest wall here. We need to make sure in our diagnostic calls that we're accounting for things like the underestimation of stroke volume and EF if it is a borderline case. Another type of artifact that we frequently see in our cine SSFPs is the off-resonance artifact. So what you can see here is we have our balanced SSFP, and you have dephasing that occurs between the pulses. So when the signal profile hits a plateau in our pulse program, it can be interrupted, and it causes these off resonance points because the center frequency may be offset here. So what that results in are these black lines that the arrows are pointing to here. And, in the case on the left-hand side, it's not something I would probably reacquire. The off resonance is not anywhere particularly close to the heart, but in the case on the right-hand side, you see that it's coming right through. If we're measuring, if this is an SFP and we're getting quantitation and it's not really affecting our border, we can probably move on. But it might be significant enough that it could cause difficulty in interpretation. So these are also called dark band artifacts. And when you have them, you'll often note that this high signal intensity occurs where there's stationary tissues near the edge of the field of view. And so they're less common if you're looking in areas of the lung, but sometimes it does come into the myocardium. Here's another example, just looking at some different views. So in this case, on the left-hand side, this artifact is causing some image degradation. And we see the black line here, followed by some hyperintensity on both sides. That's related to the shifting of signal between those pixels here. And on the right-hand image, we have another example where the off resonance is really starting to degrade parts of the anatomy we may be looking at. Because the dark band artifacts are related to inhomogeneities in the magnetic field or the center frequency offsets, we could potentially reduce them by just reshimming and retuning the imaging system. So when we have this at a level where it's going to degrade our images, we first want to make sure that our repetition time is minimized, because the reduced repetition times will help improve the gradient hardware. It also allows us to increase the bandwidth. If we need to, we can increase the bandwidth to reduce the repetition time. The second thing we can do is really limited in that the ability to minimize the repetition time is limited by a value called the specific absorption rate, or the SAR. And that is a particular factor at 3 Tesla. So you have increased attention then to the potential to shim and maximize your main field, your B naught field homogeneity. So what we can do if minimizing the TR doesn't move the artifact is that we could potentially do a volume shim centered around the left ventricle, and we can ask the patient to breathe shallowly so that the chest motion is minimized as well. And there's a third thing that we can do if we still are dealing with our dark band artifact and it's not fully suppressed after shimming, is we can take the center frequency and align it more closely with the frequency at which the water is resonating. So to do this, we would manually adjust it, or you could acquire a frequency shift scout image series like you see on the image here. And by doing that center frequency adjustment, where 0 is our native image, we can go minus or plus several hertz. And you see, as we increase our frequency, it removes that artifact. And so that's a really helpful trick here. If the patient has a device, you're probably already pre-planning this, but we know that the implanted devices are really susceptible to off-resonance effects with our CENI SSFP acquisitions. So you can see in the left image here, we've got our typical segmented steady-state free precession short axis scout, and that arrow is pointing to where the generator is up near the chest wall, causing a major dark band off resonance and ferromagnetic susceptibility artifact. And even if these devices are MRI compatible, it's fine if you're getting a knee MRI, but if you're getting a cardiac MRI, it can cause difficulties with our image interpretation and diagnostic quality. So fortunately, one of the first things you can do is switch over to a gradient echo instead of SSFP. So you can see in the gradient echo, we still have a signal void caused by the artifact, but most of the time you can recover some of this wall here. Sometimes this wall is still covered by the artifact void, but we can get at least a better diagnostic quality image here. You'll also notice that we have the lead artifact down here in the right ventricle. So I just wanted to point that out here. If we're trying to speed up our acquisitions, we're going to use parallel imaging. So this is an example of a type of parallel imaging called SENSE. And we get some residual aliasing or wraparound artifacts here. So the parallel imaging will help us accelerate our image acquisition, but there's always trade-offs. And the trade-off here is that we get first reduced signal to noise, and second, an increase in our artifacts. So we're always trying to balance these different factors that we have. But the most common application is going to be at like a 1.5 Tesla, where you have acceleration of 2. You can also use this at 3 Tesla, and at the higher field strength, the SNR will be higher, which is good, but your specific absorption rate or SAR limits are more likely to be exceeded when you're using parallel imaging. So in this example image here, you have that characteristic, quote, wraparound artifact that occurs when the reconstructed field of view is smaller than the object that's imaged. And so you can see here a lot of wrap coming from the chest wall here into our cardiac area of interest. So to remove the aliasing artifacts, we really just need to increase the size of our field of view. You can also increase your phase encoding steps, which may help. And really, we want the location of this artifact just to be outside of our area of interest. So we can sometimes shift it closer to the edge of the image if the parallel acquisition factor is reduced. So these are some nice examples here of where they've made those adjustments, and the right-hand image is free of the artifact coming through. And you can appreciate that the field of view, if we look at the width of this image, has been increased from our image on the left. One of the common things that we struggle with in first pass perfusion images is our darkroom artifact. So we'll often stack our images from rest and stress, like you see here, where time is going left to right across our columns. And a darkroom artifact is going to appear as this dark line on the endocardial surface right here. And the general rule of thumb is that if the defect persists through at least 3 heartbeats, extends into the myocardial muscle, and is conspicuous during stress, more at stress than rest, we would consider it to be a true perfusion defect instead of a darkroom artifact. So the darkroom artifacts are always going to be on that subendocardial rim, and we just have to recognize those when we're doing our interpretation. You will get that dark line at the border, and there are a couple of factors that contribute to the production of darkroom artifact. So this is where you can think through possible changes to your acquisition. The darkroom artifact has been attributed to many different types of factors, including partial volume averaging, a gadolinium-induced magnetic susceptibility, myocardial motion, and undersampling due to the low spatial resolution. It could be any single one of those, or it can be caused by multiple ones. But we know it's something that frequently occurs. And you can see on the next slide, we've got a case with the Gibbs ringing artifact here. So On the left-hand side, in our septal wall, we have a Gibbs ringing artifact. But in the lateral wall, we have a true subendocardial perfusion defect. And so you can appreciate that these things are both occurring at the subendocardial wall. But the darkroom artifact is typically only about a pixel wide. So on the lateral wall, you can see a much broader range of hypoperfusion or hypointensity. And so that gives us more information that is probably a true perfusion defect, in addition to the fact that it lasts for several heartbeats too. If we're not dealing with darkroom artifact, we're probably dealing with aliasing in our first pass perfusion images. So similar to what you saw with the parallel imaging aliasing artifact, we get an aliasing artifact in our first pass perfusion images. So you can see on the left-hand image, these lines are coming through the myocardium, which the hypo and hyperintensity caused by those artifacts could really influence our ability to determine if there's a perfusion defect. So going from left to right, you can appreciate that the field of view is increased in the middle image, but there's still a little bit of artifact coming through the myocardium. So the technologists then switched the frequency and phase encoding direction. So the wrap is now going in the opposite direction, and it's free of our myocardial space. So we're able to really interpret our images nicely there. With our LGE images, if we think back to the way that the pulse sequence and the theory of LGE is designed, what we're doing is we're looking at two different tissue signal intensities, and we pick the time to take our image, the inversion time, right here, when our healthy tissue, the black line, crosses the zero of our magnetization here. So we have this exponential recovery. If we have a 180 flip of our signal, then it recovers back. And if we take the picture at this specific time, the normal myocardium is black, and the myocardium with gadolinium recovers faster. And if we convert magnetization to signal intensity of our image, then we can appreciate that we have more magnetization and signal coming from here. So we typically are doing a 180 flip and then watching all the spins come back. But what we measure in terms of signal is the absolute value. So if we were to take the absolute value of this graph, we just take that negative part of our exponential curve and we flip it. And so it's curved in the opposite direction. But you can see that the null point for normal myocardium is much higher than the null point for our contrast enhanced tissue. And so with our late gadolinium enhancement, what we're trying to do is select a time where we have the maximum difference between those different tissue properties so we can appreciate them. And that's what we have on this graph here. So thinking back through that theory, it helps us understand some of the artifacts that come into late gadolinium enhancement. It's why we first do a scout across different inversion times so we can properly select our inversion time. If we don't get that right, then it can be a little bit more difficult to interpret our images. And so you can see a lower signal intensity at 200 milliseconds, a lower inversion time going to 300 and then 350. So if the inversion time is too short, the signal from our normal myocardium may still not have crossed that zero threshold. And so the normal myocardial signal may also be similar to that of our, if you pick the picture here, it's going to be very similar between the two tissues. Very little difference in that vertical part of the curve there. If the signal is, if the inversion time is too long, on the other hand, the magnetization of the normal myocardium will be above zero. And so then you're dealing with normal tissue being gray again. So we're really looking for that optimal time when the healthy myocardium is black and the infarcted myocardium or the diseased myocardium will light up a little bit better and give us that visual appreciation between the tissues. So these are just some examples taken on a 3 Tesla magnet, and you can see the 3 different inversion times, and the phase-sensitive images show us that there's relatively null signal of the myocardium, and we can optimize that sequence here. In LGE, we often, we may come across the B1 field in homogeneity artifact. So B0 is our main magnetic field. It's the magnet that is always on, related to the scanner bore. The B1 field is what we add to that magnetic field when we're doing an RF frequency pulse. So we're adding signal in the transverse plane and pulling those spins from the Z axis of our magnet up to the transverse XY plane. And we have to set our pulses up so that they're doing that in a very uniform process. But if there's inhomogeneity in our B1 field, we could get some signal suppression in a non-homogeneous way as well. So you can see that in this image here. It's more pronounced at 3 Tesla, but you can see on the image here that the signal is not homogeneous across, regardless of the tissue going on. It's just not a great acquisition here. So what we can do is reduce this artifact by using an adiabatic inversion prep pulse if needed. And that'll help the field just become more homogeneous. With the LGE, we can have motion artifacts, either from poor breath holding on the left, where you can see the chest wall kind of reverberate through the image, or we might have defective ECG gating on the right, where you can see that there's not this ripple around the chest wall that we have here, kind of coming through the image. We have nice crisp borders around some of these different signal intensity planes, but we can't really appreciate the myocardium very well. And that's going to lead us to knowing that it's an ECG artifact instead of a breath hold artifact. If your breath hold artifact is the source of image degradation, you can try to coach the patient through better breath holding, or you can switch to one of our free breathing MoCo type of LGE acquisitions as well. If we want to, we can minimize our phase of view in the phase encoding direction for patients who have trouble with their breath holding. And that then decreases the number of K-space lines that are required to fill the K-space matrix. And then you don't have as long of a scan because you're collecting less data, and that might help shorten the breath hold and get you some diagnostic quality back. You can also run into a case where if you're imaging with only the anterior coil elements, that could allow you to have a smaller field of view, produce some rapid artifact. So if you also want to decrease the breath hold duration, you could increase the number of K-space lines acquired per cardiac cycle. So you're filling K-space at a quicker rate and not just getting fewer lines of K-space there. And of course, we have our single shot images where we're trading off breath hold time versus our spatial resolution, but better to have that than a non-diagnostic scan. This is a case of a patient that had severe respiratory artifact on the left-hand side with our standard segmented inversion recovery gradient echo sequence. And on the right-hand side is that single shot LGE that's a free breathing. And so you can see the recovery and the image quality back to a diagnostic level scan as well, using that single shot technique here. If the patient has respiratory motion artifacts and you're looking outside or even inside the body cavity, you can appreciate the chest wall ghosting throughout the image. And that ghosting artifact is always going to be in the same line as the chest wall here. So this is an example of a PSIR in a 3-chamber view. And we just have that respiratory artifact. So you could switch to one of the other techniques I talked about. And if we have wrap, not just ghosting, which is the repeated lines here, but if we have wrap into the image, that can also cause artificial features that may be hypo-intense or hyper-intense. So on the images on the left and right, we have our short axis LGE scans. And on the left-hand side, the arrows are pointing to 2 small fibrotic areas. The left-hand image A has severe artifact, wrap artifact, that comes into the heart. So you can see how it's wrapping into the heart. And all of this up here is also wrap. Okay? We don't expect that tissue to be close to the heart. So the wrap artifact is placed outside the body in image B by changing the phase encoding direction. So just switching which way is phase encoding, if it's this way versus this way, can easily shift that wrap artifact outside of the image. It's going to be most frequently seen in the phase encoding direction. If we're doing phase contrast or flow imaging, we also can run into aliasing, but from the Nyquist theory. So here we have aliasing results in what could be interpreted as artifactual reduction in the flow that's measured. And that's always directly proportional to the extent of the aliasing artifact. So our image here is a set of images of through plane phase encoding. And so flow going to the head is white, flow going to the feet is black. If it's in between, it could be a grade level. On the left-hand side, when we set our velocity encoding or VINC too low, what you'll notice in the image on the left with 150 is that we have bright white, and then the middle of that is black, and on the boundary of that is black. It's very unlikely that we're going to have high velocity flow to the head and the feet within each other, right? So that's a really nice clue that your signal, if you think about a speedometer, you've hit the max of your speedometer and it's now gone back around the clock to 0, and maybe it's telling you you're going 10 miles an hour when in fact you're going 110 miles an hour if your max is 100. And so if you see something like this, where in the middle of bright flow, you have dark flow, that's a good sign that you have aliasing. And the change you're going to make is to increase your velocity encoding until that is gone. So in the middle panel, you can see it's increased to 200 centimeters per second. We still have a little bit of artifact. If we go up to 250, it's completely resolved. So that one's a pretty easy one to make the adjustments to. You just need to make sure you catch it right after those images come back from reconstruction so that you can reacquire it. In the next images, we're going to look at it a slightly different way here. So we're looking at some flow sequences from a patient with hypertrophic cardiomyopathy. So that probably makes you suspicious that there's some outflow tract obstruction and some high turbulence within that outflow tract. So you can see whether we set the VINC to a low value of 100, 150, 200, and 250, that when we're looking at that outflow tract, we have that stark difference between dark black and bright white. So we have aliasing wrap of our velocity. We still have a little bit at 150, tiny amount we can appreciate at 200, and it's gone by 250. Now the signal intensity in our images changes here. So you see just a little bit of bright white in the 250. We're not seeing any of that wrap to the dark. we're still quantitatively measuring the true signal and the true velocity. It's just our scale is different. It's like switching from a speedometer that maxes out at 100 to a speedometer that maxes out at 250. We're just measuring the scale across which the grayscale from black to white is extended. And so it's not that this is low flow here compared to what we had. It's just represented differently on our scan in terms of the visual appearance. With dark blood imaging, if you have slow flow, you might have trouble nulling that dark blood. So dark blood imaging as a principle similar to LGE, where instead of nulling the normal myocardium, we're trying to null out the signal from the blood. And if the blood is slowly flowing, if you have a low EF, it might be difficult to completely null or black out the blood, and you get this blood artifact at the endocardial border. In the image on the left here, so these are all short axis MR images with a dark blood inversion recovery fast spin echo sequence. So on the left-hand side, we have our repetition time adjusted so that the data is acquired at mid-diastole, and you get nice clear borders for your endocardial surface. In the middle image, the TR was set too long, and so you have blurring of the chamber walls because there's some partial recovery of that signal from the blood. That changes our contrast between the blood and the myocardium. And the image at the far right is actually, if we have too short of a TR, it can cause that blurring of the blood myocardium interface when you have the base to apex contraction during systole. So what we want to do here with our dark blood images is adjust the repetition time so the data is acquired mid-diastole so that we can eliminate the cardiac motion artifact that leads to this, this poor blood nulling right here. So we really don't want that cardiac motion. We want to get mid-diastolic acquisition. This is an example of just what ghosting looks like, similar to our LGE image. If we've got ghosting in our dark blood imaging, you'll see it kind of reverberating from the chest wall down. And this is an example of a turbospin echo T1 weighted sequence. And in the next scan, you would want to make sure that you have the patient hold their breath a little bit better. So those are our major cardiac imaging artifacts. There's certainly more, but those are the most frequent ones that I wanted to touch base on. There's also some artifacts that are caused by ferromagnetic materials, like our valves, our pacemaker wires, surgical clips. So we'll look through a couple of examples of things that could be external or embedded ferromagnetic materials that cause artifacts and how to identify them. So this is a case here of a patient that had a artifact. You can see the two artifacts on the back, left and right here. Don't know if anybody has a guess for what it is, but they were able to determine it was the magnetic slider on the bra strap adjustment to make the bra straps longer and shorter. There's a little magnetic clip usually. And so that was on the back, and that's why you have kind of symmetric artifacts. In this case, it's not impeding on the area of interest, but if you did want to make sure you had good check of the lung cavities for anything extracardiac, maybe you have to make that adjustment. In this case, we have an implanted loop recorder. So this one is at the chest wall, and it is likely going to affect the myocardial area. So switch from a SSFP to sets of gradient echoes. Things like that may help, but it is one that's less addressable than clothing, of course. In terms of implanted artifacts here, a mechanical aortic valve will definitely degrade some of the scan quality if you're looking near the valve. So in this set of images, we have are short axis LGE images, and they're acquired with an inversion recovery spoiled gradient echo. And what you can appreciate is that you have artifact here from the valve up near the base, and it's still affecting all the way down a little bit. We get magnetic susceptibility artifacts from the metal, as well as just RF artifacts that can cause a deterioration of that B1 field and the RF pulses that help refocus and give us the clearer images. And so they can cause an induction of something called eddy currents when you have metallic implants there. And it's a matter of trying to adjust the phase encoding direction and make sure you do gradient echoes and things like that. But those valves, particularly if you're looking for any flow or tissue damage near the valves, could be difficult to assess. Surgical clips are also going to cause some shift in the signal that we get. So in this example, we have a patient who was status post CABG, and you can see that there's surgical clips in the 4-chamber view that result in a round area where we have a void of signal, and we get a crescent-like hyperintensity here that can indicate what we're dealing with. We also have partial volume averaging. So these artifacts may appear in normal tissue and be mistaken for a pathologic condition. Here's a patient who had a surgery as well. This was a 50-year-old congenital heart patient, and they underwent a pulmonary valve replacement for a biologic valve. And the sternotomy has some metallic artifacts here in the chest wall that are apparent here in our image. But what you could do maybe is a half Fourier acquisition to try to remove some of the artifact. And it can, here in C, you can see the artifacts give this peripheral high signal intensity designated by this arrow, this group of arrowheads here. So just things to look for and think through if the patient didn't disclose that they had this in their history. You know, it might surprise you when it comes up. Not really as apparent as some of the other ones, but we definitely see those sometimes. And here's just a nice 2-chamber view and 3-chamber view of our aortic valve replacement. So you can see the big signal void, changes in the flow up here. What's happening on the left-hand side is we're using an SSFP image. And on the right-hand side, we switch to our spoiled gradient echo. So just like we do with our device cine stacks, we can switch over to a gradient echo. We still have a signal void, but we're able to assess the myocardial wall as well as the above upstream effects there as well too. So this was just a brief overview. We could spend a whole month series on artifacts, but a couple of take-home messages is that many, if not most, artifacts can be resolved. But what we need to do is make sure that we're identifying those artifacts during the exam and that we're able to correct them when possible in real time. Understanding the origin or genesis of the artifact is really the key to being able to get to resolution and a diagnostic scan. So know your MR physics, know your tools and what you can do to change things. Is it switching to gradient echo? Is it changing your repetition time, decreasing your phase encoding lines, things like that? And if needed, phone a friend, of course. So these are a few references that I've always found to be very helpful. A lot of these images are from Ray Kim and John Grizzard's great article that talks about optimizing MR images and their artifacts. So with that, I will leave y'all with the CME credit code and take any questions.
Well, thanks so much, Dr. Jordan. That was a really wonderful overview as always, and very helpful, the clinical and research space. It looks like there was a question, Shelley Stafford, one of our MRI technologists, asked, how do we know what the TR should be in the low flow state? I think she asked this when you were talking about the dark blood imaging. Oh, this is from a DT. In the dark blood imaging, you were talking about there was some blood pool enhancement artifact.
Oh, yes.
And if the TR is too high or too low, then it can be problematic for that.
Yeah, so what we're wanting to do is to adjust the repetition time so it's hitting at mid-diastole. So if you're not able to do it right off of visually just estimating it, looking at your ECG gating, you could do the scan and just test so that you've got, like here, I think that it was on this slide. So if it's too long, you'll have the flow. So it's a little tricky to visually say based on these images, is it too long or too short? But one thing you'll notice is the signal intensity here in the fat areas. That can be a tip. So if it looks like you have blood and it's bright in the fat, I would lower the TR. If you're having difficulty delineating it and your fat's still pretty nulled, I would increase the TR. Hopefully that'll get you to mid-diastole there. Great question.
Great, thank you. I thought of a question, which is, you mentioned the device-related artifacts, and especially in LGE sequences, and then our wideband sequences that can really overcome those. Are there any downsides to the wideband imaging? And also, do you know why, at least the sequences that we have, are all those free breathing motion corrected ones as opposed to sort of the standard segmented LGE acquisitions?
Yeah, so let me take the wideband first. You raised a good point. So typically the LGE has been very challenging in patients with devices. The artifact often looks to the same degree as the SSFP cine artifact, but there were several different investigators working at the same time on wideband LGE, one at out in UCLA and then here at NIH. And so it is now product in some versions of the Siemens scanner. So there's a wideband LGE, and it increases the bandwidth such that it shifts the artifact and reduces it, similar to how the GRE cine looks compared to the SSFP cine. So in patients with devices, if you know that you have to switch to the gradient echo on the cines, I would go straight to the wideband. There's some pros and cons with it. You get some diagnostic quality first off, so it's definitely better than going without the wideband. Depending on the version of wideband you have, the spatial resolution and the signal to noise ratio, they do sometimes suffer, and so it can have multiple averaging. So it's just something to be aware of. To boost the signal to noise, it may average over several heartbeats and cause issues if there's poor gating. But they do tend to appear just more grainy than what we have with our standard LGEs. And then there was a second part to your question.
Yeah, I was just wondering, is it a limitation? The sequences that we've always seen have been those free breathing motion corrected ones, as opposed to what we typically think of as, the high resolution segmented LGEs. I was just wondering, is there a reason for that with the wideband techniques specifically, or that's just how
From my
they chose to
understanding,
develop them?
yeah, it's so that they can boost the signal. So they have to get it over multiple heartbeats. And so it's free breathing, and then it's motion corrected because of that breathing artifact. So you will notice that the images side by side are pretty grainy compared to a patient who's able to get our nice segmented LGEs. But it is better than getting nothing, I guess.
Got it. Thank you. Well, if
Jennifer,
there,
great job. Just one thing I would say on the stress perfusion, you were talking about the dark rim artifacts and ones that are present longer than 3 heartbeats might be real perfusion defects. I'm not so sure about that, at least the way we're doing them. Generally, what we seem to think clinically is if they're present for less than 5, it's much more likely just to be a rim artifact. 5 to 10, we're not sure, and then greater than 10, we kind of consider as, concerning. We couple that though with also, are they matched at rest? The rest imaging, in addition to the vasodilator stress images, and actually the thickness of the low signal relative to the total wall thickness. If it's greater than 1/3 of that thickness, that's usually not associated with being an artifact. So just a couple caveats. And remember, we use sort of the gradient echo images. We don't use the steady state free precession ones for those perfusion assessments. If you do use the steady state free precession ones, all of those artifacts are much more demonstrable.
Absolutely.
Great job. That was a beautiful presentation and just very well described and outlined and organized. Super job.
Thank you.
Yeah, I agree, Jennifer. Just great.
Thanks, John.
all right, well, we're at the end of the hour. So thanks again, Jennifer. That was really wonderful. And we'll see everybody back next week.
Sounds good. Thanks, everyone.